From the St. Francis Yacht Club in San Francisco, this is the Wednesday Yachting Luncheon, hosted by Ron Young.
Welcome to the Wednesday Yachting Luncheon, live from the virtual grill room of the St. Francis Yacht Club. We hope that you and yours are safe, sheltering in place in a comfortable environment, and free from any danger in this pandemic. And speaking of pandemics, well, we certainly have a great speaker today. Art Reingold, after getting his bachelor's in biology at University of Chicago, our speaker today stayed for the full program and went on to become an MD in epidemiology. What a timely expertise for us to have on the Wednesday Yachting Luncheon. Art Reingold was a consultant to the St. Francis Yacht Club during 2020 and is an esteemed professor at UC Berkeley School of Epidemiology. This is your second tour of the Wednesday Yachting Luncheon. Welcome to the Wednesday Yachting Luncheon.
Good to be back with you.
Now, you're an expert in epidemiology, and we're going through a centuries historic pandemic. I'm looking forward to your presentation, and everybody in the audience has a vested interest in learning something from you today. Everybody in public health has to wait for half a century or so to get the kind of starring role that your profession has right now. Does it feel like we are safer this time around than we were, say, 30 years ago, 40 years ago, 50 years ago? Had the same pandemic come in the 80s, would it have been a bigger issue in America?
I think the answer to that is complicated and mixed. We certainly have better technology. We have much more quickly developed diagnostic tests, and as everyone knows, to develop vaccines in an extraordinarily short period of time. So those technologies wouldn't have existed 30 or 40 years ago, and our response would have been slower as a result. But the reality is that the public health infrastructure in the United States is not one thing, and it's not constant over time. Our Constitution says that health is largely a state function. So the public health infrastructure is different in each of the 50 states and the half a dozen territories and a few Native American tribe territories. So it's complicated. We're not one country when it comes to all of these things in many ways.
Which state has the most protective public health policies when it comes to the pandemic?
I'm not sure I know the answer to that. I think many states have struggled to be science-based and to do the best they can and to keep up. And other states clearly, with different political leadership, have gone in a very different direction with more of a focus on providing advice and letting people decide for themselves rather than trying to impose limits or constraints on people.
When you were a little kid and you were imagining your profession when you were 4 and 5 and 6, what's the first profession you thought you'd have?
I wanted to be a plumber.
Not far off.
Then I thought I'd be a mathematician like my father and my older brother until I discovered I had virtually no mathematical ability. So, when I was quite young, my mother died quite prematurely of breast cancer. And I think that influenced my interest in going into medicine. So even when I went to college, I think I'd already decided that I wanted to go into medicine and have a focus on research. Although I think my vision was of laboratory-based research, win a Nobel Prize for curing cancer or something like that. So it really wasn't until after my medical training that I learned about public health and sort of moved into that arena. So that's a cartoon of the SARS-CoV-2 virus that causes COVID-19. It shows the spike proteins on it that are important to its attachment. Just one quick note, this has today's date on it. I prepared the slides a few days ago. And for many presentations in diseases, a difference of a few days doesn't really matter very much. But with COVID-19, every day brings new revelations and considerations and reactions. So by the time people are watching this, it'll undoubtedly be a little out of date. Viruses exist to make more of themselves, and they do it in different ways. But one of the things that they have to do, whether they're infecting plants or animals or people, is they need to find some way to attach to cells within the body. And so for the SARS-CoV-2 virus, we have what are called these spike proteins. That's what these red protuberances are. And those allow it to attach to certain cells within your respiratory tract or the respiratory tract of, it turns out, a number of other animal species.
Are these existing in our bloodstream? Where do these viruses hang out in our bodies?
Typically, the infection with this kind of virus is in the upper respiratory tract, the nose, the throat, and then proceeding down into the lower respiratory tract. It turns out that the virus or parts of it are shed in the feces as well, which is why people are now doing a lot of what's called sewage sampling to monitor the epidemic. But its attachment is in the respiratory tract.
And its goal is to breed, to grow.
The goal is to make more of itself. Viruses, like other living creatures, are constantly evolving, spinning off genetic mutations. Some viruses do a lot more of that than others. This particular virus does it a lot. So it makes mistakes when it's copying its own nucleic acids. But on occasion, one of these changes or some set of changes results in a virus that's easier to spread. And we have that now with the Omicron variant. And so that then takes over because it has an advantage compared to the other strains. There are other viruses that are really very, very stable and really don't change very much. But this virus, hepatitis C virus, the HIV virus that causes AIDS, are examples of viruses that mutate a lot and spin off variants all the time. What viruses do is they take over certain cells in your body and change them into little factories for making more virus, because the viruses can't replicate more of themselves unless they're inside of a cell.
Okay, and this viral particle, what keeps it alive? How does it live and what makes it die?
Many biologists would say that technically viruses are not alive, although I think most people would classify them as living. They basically want to assemble more of themselves. They do that within cells, in this case, in your respiratory tract. And so you can go from having very few of these viral particles to having tens of billions or hundreds of billions within a relatively short period of time, and then potentially transmitting the virus to other people.
And so if there's one here and then sometime later on, there's several 100,000, what happened to that particle that I've been looking at? Is that particle still around? Is it morphed? What's happened to it?
That's a good question. I'm not sure I know the answer to that. In a human being, of course, our immune system is busy responding and trying to inactivate these viruses. So some of them will be inactivated or killed by the host. And what happens to an individual viral particle, is that some of them are killed by the host, some of them go on to infect other cells. The virus that causes COVID-19 is called SARS-CoV-2. And you get into this question of where did it come from? And the evidence is that it originated either in a bat or in something called a pangolin, ultimately made it into people. And of course, there's a lot of controversy whether it escaped from a laboratory in China, whether scientists there were intentionally manipulating the virus. The reality is we don't know the answer to that question. There's a lot of politics involved in addition to.
What is that thing in the lower right-hand corner? That's a pangolin?
That's a pangolin.
Is it like a little worm? What is it?
No, it's more like an armadillo. So anyway, this virus and one's very similar to it live in bats.
Why are bats a good medium for transmitting these things?
Well, it's a great question. And it turns out that the bats, are warm-blooded. They're mammals. And I don't really know the details of this, but they have an immune system that makes them particularly friendly to having been infected with a pretty substantial range of different viruses that don't necessarily kill the bat. But somehow, whether in a wet market, whether in a laboratory, this virus made it into people. And most of the evidence is that occurred somewhere in the middle of November of 2019. So pretty much just a little over 3 years ago. And it may all have resulted from a transmission from a single infected animal. And we may never really know exactly what happened. So, as I said, this is a highly political issue with countries and politicians accusing China of various things and really not much visibility into exactly what happened in China.
Who does the World Health Organization report to? What's its funding source? And how is it structurally connected or not to governments?
Well, WHO is part of the UN, and technically they're an independent organization. They don't have an army, so they can't invade a country. They really have very limited ability to force countries to do things. The main office is located in Geneva, and they're supported by funds from member countries, obviously mostly rich countries. They also get a lot of funding from grants from the Gates Foundation and others for specific projects. So they have scientists and other people working on many health issues. But even with resources, they can lead scientifically, they can lead by proposing policies, but they don't really have the power to enforce things.
Was America's preparedness for this pandemic affected by eliminating protective programs that used to exist before the pandemic?
Under President Obama, about $1 billion of U.S. tax money was used to try and improve capacity to detect and respond to outbreaks, working with and building capacity in countries like Kenya and Thailand, and I think a total of 30 or 40 countries altogether. When that funding ended, it was not renewed by the federal government. And so, you could argue that some of that capacity shrunk. But the reality is that having and maintaining that capacity in many countries is incredibly complicated and difficult problem.
What's our connection to the World Health Organization? Do we have a representative that is assigned to liaison between them and CDC? How are the two connected?
Well, they work together quite closely. And in fact, most of the Americans who are working at WHO in Geneva are in fact employees of the U.S. Centers for Disease Control and Prevention rather than employees of WHO. UN agencies pay a lot of attention to bringing people from many countries, so they don't hire many Americans, but there are large numbers of Americans there working side by side with WHO employees on everything from hepatitis to cancer to pandemics like COVID-19.
So you as an epidemiologist, how often do you talk to somebody who actually works for the World Health Organization? What's the occasion?
Well, I used to talk to them quite regularly because I was on a number of advisory committees around vaccines. So I would be in Geneva 3 or 4 times a year for meetings and be talking to people regularly. Now I'm on one advisory committee for WHO. So I do talk to people there, but I definitely don't work for them.
One of the things that's remarkable about your service for the club is that you're the Western States Coordinator. What is your official role with regard to COVID and the state of California and the Western states?
So some listening to this may be familiar with the fact that a year and a half or so ago, the governor of New York, in fact, decided to stand up a scientific review group to look at vaccines against COVID. And Governor Newsom followed shortly thereafter. And then a decision was made that 3 other states would join California in this activity. So those 3 other states are Washington, Oregon, and Nevada. And we are called the Western Scientific Safety Review Working Group. And so we report to the governors of the 4 states. I chair that working group. And the purpose of the working group, which is comprised of phenomenal experts from all 4 of the states, is to advise our governors with regard to these new COVID vaccines as they come out, as they're approved for use in different populations. So we meet immediately after the ACIP meets, which is the advisory committee to the CDC, look at the evidence that's been presented with regard to safety and effectiveness of these different COVID vaccines in different age groups and the like. And we make recommendations for how the vaccine should be used within our 4 states.
this 4-state advisory committee includes doctors from the region beyond just the San Francisco Bay Area?
So altogether, there are perhaps 20, 25 people on this working group. And believe me, they have expertise among them that is unparalleled anywhere in the country. Okay, so this is just to say there are many, many viruses in animals. By some estimates, over 2 million different types of viruses. And periodically, we have what are called spillover infections, where a virus that's normally in animals spills over into and infects people. And if that can then be transmitted from one person to another, can cause real problems, such as Ebola and things like that. So most of the viruses in animals do not or cannot infect people and cause problems, but occasionally they do. And so SARS-CoV-2, the cause of COVID-19, is just the most recent profound example of that. So this just to remind people, 3 years ago, almost exactly to the date, there were 12 known cases of COVID-19 in the United States, 6 of them here in California, 2 in Illinois, and 1 each in 4 other states. Now, we know now, based on studies, that many more people were infected with this virus by this date, but there were 6 known cases. And just again, the early history here, the World Health Organization 3 years ago, I think it's fair to say our knowledge has evolved over the past 3 years. So some of these things we know are not true, but they reflected people's thinking and understanding at the time. So, for example, the statement that there's no significant human-to-human transmission, in retrospect, was clearly wrong. The issue of restrictions on international travel is a very complicated one. And then there was an evolution in thinking by the World Health Organization and by the Centers for Disease Control about what people could do to protect themselves. And our thinking about things like masks has certainly changed over the past 3 years. But this is just to show that people did the best they could with limited information, but clearly some of that was probably not correct. So many different things were done to try and reduce transmission of this virus, isolating sick patients to protect healthcare workers and other nearby patients, quarantining people who'd been exposed but who were not ill, or doing sanitary and protective sequestration, basically, or blocking travel in and out of an area, such as the Chinese did to try and prevent transmission. The controversial issue of travel restrictions, we're all familiar now more than we want to be with social distancing and closing of schools and the like. Hand washing has been certainly part of the response, and hand washing is an important public health measure. It isn't clear to me how much it matters with regard to COVID-19, but many people would say it's an important part of that response. You'll see people in many places spraying street corners and subway cars with all kinds of chemicals. I think that is completely pointless, but it's what I would call security theater. It makes people feel like they're doing something. So people did many different things to reduce the scope of the problem. At the same time, because there are lots of sick people, the medical profession quickly tried to ascertain what existing treatments might be helpful, including some drugs that in retrospect were not helpful at all. And people even thought that perhaps the very old vaccine against tuberculosis might be having some effect on the immune system with regard to preventing COVID-19.
What's the efficacy of any of these medicines in preventing or curing COVID-19?
Corticosteroids do appear to reduce the risk of dying if you're very sick and in a hospital with COVID-19. There are some antiviral drugs that have been produced now that newer ones that do appear to have some benefit. There's absolutely no evidence that vitamin D changes your likelihood of getting sick or dying from this disease. And the evidence is quite good that hydroxychloroquine and ivermectin simply don't work. So that's the past. Now let's talk about the present. And again, this was taken from the WHO dashboard now 7 days ago, so it's a little out of date. But you see these numbers in the last 24 hours, almost 3 million people reported as cases, over 386 million reported cases around the world, and over 5,700,000 deaths. And we know that these are vast underestimates of the numbers of cases, and certainly some underestimate of the number of deaths. Very difficult to know exactly what those numbers are.
Are these numbers going up or down?
The number of cases being reported a day is still going up in some parts of the world. It's going down in other parts of the world. But those numbers are just so unreliable that I wouldn't say they represent very much. The number of deaths Again, in some areas, it's continuing to go up. Here in the United States, we're currently at about 2,500 deaths per day from COVID-19, and that's fairly high. But I would expect that to go down in the coming weeks.
Deaths is the trailing, if I could just use the term, it's the trailing indicator, right?
That's correct. So deaths are in some way a better, more reliable indicator in some ways. They're easier to count, although there are problems with that as well. But they're a trailing indicator, you said, because between the time you get infected, when you get hospitalized, when you die, if you're going to die, is typically at least 2 to 3 weeks.
Respiratory weakness, or does that affect your likelihood of dying in it?
Many people have what we call multiple comorbid conditions. So, lots of people may have high blood pressure and obesity and lung disease or diabetes. So, unfortunately, many people have 2, 3, 4 of these conditions. It's a little hard to tease apart which ones are independently associated with more problems. But having these underlying conditions makes you at greater risk for all kinds of problems, not just COVID-19. So again, this is February 7th. These are the data from the World Health Organization, and basically showing on top the number of cases, on the bottom the number of deaths. You can see this ebb and flow, if you will. Some of this has to do with new variants like the Omicron. Some of it has to do with seasonality. Some of it has to do with human behavior.
Seasonality, is it when people go indoors that they're more likely to get it?
I would argue that this is like a lot of other respiratory viruses, like influenza and some others, where there is an effective season, and that the cold winter in places that have it, or changes in humidity and temperature, do change the dynamics of the virus transmission. They also clearly influence people's behavior, how much time they spend indoors versus out of doors. If you live in Buffalo, New York, spending more time outdoors in December and January is harder than in June and July. So I think there are complicated factors in terms of these peaks and valleys that, are hard to disentangle. And of course, as it shows on the top, we're also busy vaccinating people. And I'm quite certain vaccines have a lot to do with some of this ebb and flow in different parts of the world. These are the numbers, different regions of the world. And again, these numbers we know are really not very accurate. But if you look at death rates, deaths per 100,000 people from COVID-19, it's sad to say, but America is number one.
What's the population of Africa? I've lost track.
I'm embarrassed to say I don't know, but I think maybe in the range of 400 million or something.
Why are cases, transmission so low there? Is it the isolated nature of the population?
It's a great question. And I think part of this is underdiagnosis, undertesting in many poor countries in sub-Saharan Africa. The tests are not widely available, so you could have cases without being able to confirm them. It's also possible, for various reasons, there are in fact fewer cases in sub-Saharan Africa. I think that people are very interested in that question, frankly. So here are the cases per capita per 100,000. And so here you can see, for example, the red line is the United States and Canada, and we're number one. But again, some of this around cases per 100,000 is influenced by who's getting tested and the availability of testing. But, there's a lot of testing going on in Europe. So this is not all just an artifact of who's getting tested. If you look at death rates that do reflect closer to reality, America is absolutely number one. That's not just because of more testing or something like that. That's unfortunately a fact. This again reflects a complex set of factors. Undoubtedly, the effect of vaccination, number one. And number two, immunity in the population because of the spread of Omicron and more people having been infected and immune. And there could be some effect of seasonality or other factors. But it's absolutely a real decline. Here are the data on deaths in the United States. As it shows here, it took 89 days to reach the first 100,000 deaths in the United States. You can then just see the intervals in terms of how many additional deaths. So whether you look at deaths per day, currently at around 2,500. If you look at cumulative deaths, which is at this point over 900,000 people dying of COVID-19, the United States has absolutely done the worst of any country if you measure it in terms of COVID-19 death rates.
I don't want to be political. I know you don't want to be either, but I wish I could see a red state versus blue state version of this chart.
There are such analyses. They look at whether counties are blue or red. and their death rates, or whether they voted predominantly for Biden or for Trump. And the correlation is extremely high. It's really partly a question of are you vaccinated, and partly a question of do you do anything to reduce your risk of getting infected.
This chart's fascinating because the space between the red verticals is how long it took for 100,000 people to die. And thus you see that steep peak there at the end of 2000. And then you see that we're now in another one of these steep peaks right now.
And that's because of the Omicron variant, which, while perhaps slightly less severe in terms of the illness it causes, is much more transmissible. So we just have very large numbers of people getting infected. And even if a small percentage of them die, that can be a big number of deaths. I think people know this, but I do think the New York Times has done a very good job of producing, credible articles on every aspect of the pandemic. So you don't need to go to scientific journals. You can basically see well-reported information that's available to the lay public.
Mm-hmm. Fascinating.
So everybody knows that COVID has had enormous effects on every aspect of society. It has an impact on availability of treatment for other medical conditions. It's had a huge impact on people accessing routine other preventive services, childhood immunizations. It's increased malnutrition, access to education. Obviously, everyone knows this. It's had profound impacts. And I'm sure authors will be writing books about this for years to come. So as we already talked about, this virus mutates very quickly. It spins off what we call variants. These are all SARS-CoV-2 viruses, but they're different at a molecular level. We had a huge wave last year of Delta, and we're currently in a huge wave of Omicron, which has pretty much taken over and responsible for the vast majority of infections here in the United States and increasingly in other countries of the world. And again, this is just the natural biology, if you will, of viruses. Now, treatment of people with COVID-19 has improved somewhat. We still have some benefit from the corticosteroids. We do now have serum from patients who have recovered, convalescent serum. We have what are called monoclonal antibodies. Some of these are still potent despite having Omicron. Others reduce or little effect against Omicron. And we are beginning to get some antiviral drugs. These primarily at the moment, if taken early, will reduce your risk of ending up in the hospital.
What's the mechanism of corticosteroids that makes it effective?
Not my area of specialization, but I think the general sense is that a lot of the damage done by this viral infection is the body's inflammatory response. So the response to an infection is meant to help clear the infection, but sometimes it can produce damage to the body as well, and that corticosteroids reduce that inflammatory and immune response during the most acute time period.
And convalescent serum is when you take serum out of somebody who's recovered and you inject it, transfuse it into a person who could get sick.
Yes.
And how do monoclonal antibodies, how are they effective?
So these are basically made in a laboratory where you make antibodies to various parts of the virus, the spike protein, for example, and then you put them in a bottle. There's one product, for example, for people who are immunosuppressed, where you can give an injection of these antibodies, and it's called passive immunity. You don't rely on your body to make an immune response the way we do with a vaccine. And that those antibodies can protect you for, looks like, at least 4 to 6 months. Those are typically used only in people who have severe immunosuppression and who we worry will not respond to the vaccine. Molnupiravir is an antiviral drug developed by one of the pharmaceutical companies that again basically is being used to treat early COVID-19 and has been shown to reduce the likelihood of ending up in an ICU or dying. Well, remdesivir is controversial at this point, and while there was early evidence of it working, my understanding is at the moment the evidence for remdesivir working against the current variants is pretty much absent.
We can't see that it's effective. It's gotten lots of press, more than the others, but you're not sure it's effective.
I think the evidence at the moment is that it's no longer working very well. And companies are obviously working to develop other antiviral treatments, but they're not, I don't know that there's anything going to be available anytime soon. So treatment is important, but it's not the answer to this problem. The answer to this problem is prevention, primarily through vaccination. And so everyone knows that different companies around the world, people in India, people in China, people in Russia, have taken different approaches to making COVID vaccines, coming up with effective vaccines in literally months. That's the good news. The bad news is that makes some people nervous about whether we really know enough about their safety to be willing to take them or give them to their children. All of these approaches have been tried. All of these approaches have led to vaccines being given to large numbers of people.
Sputnik 5, is that something that they invented themselves, or is this something that they copied, grabbed from somebody else and renamed?
As far as I know, this was developed de novo by the Russians. As we can come back to, some of these vaccines, like the Chinese vaccines, are being used very widely in many parts of the world. And some of the evidence is they're not as effective as some of the others.
Talk to me about the difference between Moderna's effectiveness and the others.
Moderna and Pfizer have pretty comparable effectiveness. So there's not a big difference between those, to be honest.
Okay.
The AstraZeneca and Janssen vaccine have good effectiveness, but I would say at the moment the evidence is that the mRNA vaccines have, on average, better effectiveness than the other vaccines, as far as we can tell.
And remind us, mRNA, what does that acronym represent?
It stands for messenger ribonucleic acids. And it's there's been research ongoing for using mRNA for vaccines for 20 to 30 years, but this is the first vaccine that's being given to people using this technology. And what it basically does is it takes the recipe for making the spike protein of the virus, and having your body get that message and start making that spike protein, which you then develop an immune response to.
Okay, so it heightens my defensive mechanism inside my body.
That's correct. But, as many people think it's going to change their DNA, there's absolutely no reason to think that's the case. So again, as of last week, a little under 5 billion people around the world have gotten one or more doses of a COVID vaccine. But you can see that rich countries and people living in rich countries account for a disproportionate share of the people getting COVID vaccine at the moment. This has been the subject of lots of discussion about equity, how rich countries like the US, how pharmaceutical companies can help get more vaccines to poor people, issues around patents and manufacturing that are complicated. I would just say that one question is availability of doses of the vaccines. The other is getting them into the arms of people. And getting them into the arms of people in poor countries, in rural areas, et cetera, has many challenges associated with it. It's not just having doses of the vaccine. We like to say vaccines don't protect people, vaccinations protect people. You need to get it into the people, and that can be a challenge. So if you ask who's done the best job of vaccinating their population, these are the top countries, and you'll see the US is not in that group. United Arab Emirates is number one, Portugal, Cuba, Chile. So you could argue, well, Cuba's an island and it's sort of a communist country, whatever. They can control their population. UAE is a small, well-organized country, but we're talking about countries like Singapore and Cambodia and Malaysia doing a better job of vaccinating their populations than the United States is.
So let's go through the columns. The first is vaccinated. So the 49% of the world, is this adults or is this the total population?
This is basically looking at adults.
Okay, 49% of all adults in the world are now vaccinated. And the UAE is like 2x that, literally 98%. Okay. And the per 100 people, I don't get the column way to the right.
For every 100 people in the world, 88 doses of vaccine have been given, but rich people in rich countries account for a lot more of those doses than poor people in poor countries. And so we have many people who don't believe these vaccines work. They don't work as well in preventing infection as they do in preventing death from COVID-19. And so if you just look at the graph on the right, what you basically see is that unvaccinated people are about 20 times as likely to die of COVID-19 as fully vaccinated people. So the vaccines we are giving in the United States are working. They're doing what we want them to do, which is to keep people out of the ICU, off ventilators, and from ending up in the cemetery. Okay? And they're about 90 to 95% effective in doing that. And the evidence is absolutely clear on that point. Okay.
I wish I could send this to a couple of friends of mine.
Yes, well, I have not much luck convincing people of this, but who are not originally convinced, but the evidence to an epidemiologist is overwhelming that these vaccines are doing what they're supposed to do. Currently in the world, we know that mandates for vaccination are deeply unpopular. Some of this has been adjudicated in our Supreme Court in terms of which federal agencies can mandate vaccines. Different states, of course, have taken different approaches. We are really 50 different states and a half a dozen territories. We're not one country with regard to our public health laws. Everyone is aware of the extraordinary events going on in Canada at the moment with truckers, but there are comparable things going on in Europe and other places where people do not want to be told they have to be vaccinated or wear masks. But anyway, it's clear to people like me that some of these measures absolutely do what they're supposed to do. But then there's this incredibly important and difficult issue about how do we get people to believe me, to vaccinate themselves and their children, and to do some other fairly sensible things. And it's become a highly politicized and very, very difficult issue. We have public health officials quitting or being fired left, right, and center because they believe in vaccination. We have public health officials having their homes picketed, having their children threatened. It's really an extraordinary problem, frankly. Currently, I have vaccines in the United States for people over the age of 5, but in the next few weeks, we will be seeing a discussion about expanding COVID vaccination down to younger children. COVID vaccination rates in children 5 to 16 years of age are way below what we'd like them to be, and that reflects the fact that many parents do not worry about COVID, but they do worry about COVID vaccine, and they're simply not convinced that the vaccines are safe and necessary for their children, even if they sometimes have had them themselves. So this is a major issue and will be a major issue when some states like California begin to mandate COVID vaccination for entry into schools next fall.
What's your position? What should we do with COVID shots for kids?
So I'm pro-vaccine. I've worked on vaccines for 45 years. School entry mandates for childhood immunization had dramatic effects on the health of children. We don't have measles in our children. We don't have a host of other diseases. And I honestly don't understand why COVID would be any different. It's clearly a critically important piece of getting kids back in the classroom, unmasked, able to safely learn. The vaccines, have a very good safety profile. So I personally am in favor. I can tell you my 2 grandchildren, as soon as the vaccines are available, they're 19 months old at the moment, both of them will be vaccinated. So I do think it's important to say, no one should ever say that a vaccine is perfectly safe. In fact, nothing in life is perfectly safe. Getting on BART in the morning is not perfectly safe. Getting on an airplane is not, living in the Bay Area is not perfectly safe. Right? So if you're looking for perfect safety, you're out of luck in every sphere of your life, right? Are there rare side effects from these vaccines? Yes. But the benefits far, far, far outweigh the risks. People know that just yesterday, as we're sitting here, that California and many states on the East Coast are planning to lift their mask mandates here in California, in the Bay Area. At least one county, Santa Clara, and in Southern California, Los Angeles, have said they're not prepared to do that yet. In California, counties can be more restrictive than the state. They just can't be less restrictive than the state. So a county is well within its rights to say we're not ready to lift the mask mandate yet. I was on a call this morning with the other 9 UC campuses to figure out what we're doing. And of course, each campus exists within a county, and so there's complexity to all this. Furthermore, there are students, there are faculty, there are staff, there's OSHA, there are worker laws about worker safety. It's a very complicated calculation, frankly.
In terms of the effectiveness of masks, there's people who have COVID who wear a mask and thus spread it less likely. And there's people who are outside. Talk to us about the ability to keep the disease inside the mask or to keep it from coming into you from outside the mask.
I personally don't think masks are necessary outside because I don't think there's much transmission of this virus outdoors. So I don't wear a mask when I'm outdoors. Indoors, the evidence is that different types of masks, N95, KN94s, et cetera, do reduce both infection by and infection of the person wearing the mask. So transmission in both directions. Cloth masks are clearly less effective, and surgical masks are somewhere in between. So some people who really want added protection can have double masks. They can wear N95s, whatever. But it's a complicated question, frankly.
We've also had activities lately where many people are vaccinated and where we've not wanted people to play musical instruments because a horn can sort of potentially spray contaminants from person to person. But I had a question about drums. Can a marching drum, for instance, spray contaminants? Or what's the safety factor of a drummer going through a dining room or a facility beating a drum?
So I would judge that to be quite a safe activity. Obviously, you're introducing an additional person. But if that person is masked and vaccinated, the risk, and particularly in an outdoor setting or a setting with a lot of ventilation, the risk is really quite minimal. And obviously you can't play a trumpet wearing a mask, as far as I can tell, but you can play a drum. And beating on a drum should in no way be responsible for transmitting this virus.
Right, that kind of thing is safe.
The future. So old people in the audience will know who this guy was. Famous New York Yankees baseball player who said many interesting things that on deeper reflection have a great deal of truth to them. To say that it's hard to make predictions about the future is true. It points to the obvious, right? So here are my predictions. We will have new antiviral drugs over the course of the next few years that will be discovered, and some will be approved for use. But I don't think they're going to revolutionize anything about how we deal with this as a pandemic. Of course, like many things, they will be more widely available in rich countries than in poor countries. And that's unfortunately one of the injustices that we have globally. And I don't think that's going to change in my lifetime, unfortunately. I believe that this virus will continue to circulate globally and become endemic, meaning that some people will get sick. Some people may get very sick, but just like influenza and some other viruses, we're going to have to learn to live with it. And that new variants will arise, but it's impossible to know whether they will be more transmissible, produce more serious illness, or produce escape from vaccine-induced protection. And we're simply going to have to monitor and watch what happens. I think we'll continue to have COVID-19 just like we have influenza. It's very likely we'll have peaks in the winter in places that have winter, and that we'll have localized outbreaks, but we'll come to see it as another respiratory infection similar to the flu. We will continue to see that most of the hospitalizations and deaths from COVID will be in the elderly and those with underlying illnesses, and overwhelmingly in the unvaccinated. So I don't see any reason why any of that would change. It's entirely possible that we could get to a state of having booster doses of COVID-19 beyond the 2+1 that you got and that I got. And we're going to have to wait and see about that. Could it get to the point where we have an annual COVID shot, just like we get an annual flu shot? That's possible. But nobody really knows if that's going to be the case or not. The vaccine will become increasingly available in low-income countries, but it's still going to be a challenge to get it into the arms of people, particularly in rural areas in poor countries, because the infrastructure and the staffing simply need to be dramatically improved. We've already talked about the fact that in the coming weeks, we're going to have a very complicated discussion about when we know enough to extend these vaccines down to children 6 months to 4 years of age. The FDA, I understand, going to consider this next week, and the US ACIP will have to consider it immediately afterwards. The Western State Working Group on COVID vaccines that I happen to chair for the governor will also have to look at all this after the FDA and CDC. But we will have vaccines for younger children relatively soon. I'm pretty confident of that. Finally, people are working on vaccines that don't require an injection, nasal vaccines. We do have nasal influenza vaccines where you get it through the nose, not as a shot. That avoids the phobia about needles and fear of, et cetera, and it may produce better immunity, but those will be a while in coming. This is an effort to get more vaccines against COVID into poor countries. This is by collecting donations from wealthy countries, from Bill Gates and other wealthy individuals and foundations. You can see this was back in September. I don't know how much they've raised since then, but this is part of the effort to get vaccines more widely available. And again, this is simply to say that having vaccines in a box, in a fridge, in a capital city is one thing. Getting them into the arms of people in remote areas or areas beset by war and famine and revolution and the like is a big lift, and it's going to take lots of resources.
What's the nature of evolution of a virus like this at this stage in the pandemic? It's like 2 years on, and I'm seeing the numbers of infections dropping at a very steep rate. Give us your crystal ball reading about what's going on in the next month or 2 months or 3 months. What do you expect? Are people going to be more inoculated by group infection or what? What's going on there?
Well, it's a complicated picture, and I think that the short term, over the next few weeks to months, I think virtually all experts would prognosticate that numbers will go down. It's already leading to a sharp decline over the past few weeks. I think that'll continue at least into the summer, unless some new variant emerges and changes the situation. I think what's a little less clear to anyone who wants to be honest about it is what's going to happen next fall and next winter, a year from now. Whether there's a new variant or not, how well protected will we all be from our vaccinations? Will there be waning immunity, a need for additional booster doses? So I think a lot of us are already starting to think, what can we envision for next fall? And what do we need to be prepared for just in case? But I would argue that for at least the next 3 to 5 months, the likelihood is we'll see sharp declines and a lot less COVID than we've seen over the past few months.
What's the status at the end of what's the end of the pandemic look like? What would it look like?
Well, lots of people have written about that. I think that people who know about viruses would say this coronavirus is not going to disappear from people in the face of the earth in the foreseeable future, at least not with the vaccines we currently have. So the general feeling is that the virus will continue to evolve, spin off new variants, and will become endemic in the population, the same way that influenza viruses or other coronaviruses are. And what that means is, yes, we might have an annual COVID shot, perhaps, or perhaps not. We will have periodic individuals getting infected and sick and unfortunately hospitalized and dying, but it will not be occurring at pandemic levels. It'll be more what we call sporadic or endemic.
Yogi Berra said that it's really difficult to predict things, especially things in the future. So we're going to go a year ahead now. We're going to say February 2023. Is there going to be nobody asking your advice about the pandemic? What are they going to be asking the expert Art Reingold?
I think there'll be continuing questions about vaccines and who should get which vaccines and how often they should get them. So I would expect a lot of continuing interest around the vaccination piece. My guess is that by and large, we will have no longer be seeing people masking in public, except for people who feel the need to do so, and that to a certain extent will, quote, be back to normal as it existed a few years ago, for better or worse.
By February 2023, our best expert tells us it's likely that we could be back to normal. This is pretty good. I wish Yogi Berra were here just to hear that somebody did actually make a prediction about the future.
The question is, when you call me in February of 2023, will I have turned out to be right or completely wrong?
So you and I are old enough to remember polio. I still know buddies who got polio back then and were handicapped, have a limp or otherwise had a deformed leg or arm or so on. So do we have any charts that show the vaccination rate in America for polio and compare it to the vaccination rate with COVID or other previous vaccination acceptance rates?
So I think the comparisons, and I'm old enough and have worked enough in other countries that I've seen kids with acute paralytic polio, mostly in West Africa. And I would point to a couple of important comparisons. One is that if you read the history or were alive then, you'll know that polio was raised enormous fear and anxiety. People closed swimming pools. They wouldn't let their kids play in the summer. But the fear of polio was palpable. And so it really motivated people once there was a vaccine available to get their kids vaccinated. I would point out that the other important comparison to polio, people say, well, most kids who get COVID don't get very sick or they don't get sick at all. Why should we worry about this? Right? And I would point out that that was pretty much true for polio. So out of only about 1 in 200 children who got infected with polio virus developed paralysis. Okay, so the vast majority of kids who got infected with polio were totally asymptomatic or had very mild self-limited illness. But we really wanted to prevent those kids from being in iron lungs. We really wanted to prevent those kids from dying of polio, even if they were a tiny percentage. So I think there is a relevant comparison to polio. We're pretty close to completing eradication of polio. We still only have wild type polio in Afghanistan and Pakistan, where there are major impediments to finishing eradication. But, if you've worked in poor countries, you will have seen many, many people sitting by the roadside selling pencils or candy or whatever it is, who can't walk in wheelchairs, and they're the survivors of polio.
I asked the question because my guess is the polio vaccination rate was much steeper than the COVID-19 vaccination rate. When I was a kid, I don't remember any resistance to people getting the vaccination immediately as soon as it was available. So the question I ask is, do we have any comparisons of the vaccination rate with that vaccine compared to COVID-19?
I think the problem with making that comparison is polio vaccine campaigns were targeting children. And COVID-19 vaccines so far have been targeting adults. And so I think it's a little hard to make a comparison. I don't have the numbers specifically to answer your question, but you do need to keep in mind that we're talking about very different age groups.
So that leads me to wonder, well, since polio was very, very effective, as soon as we start vaccinating kids, maybe the death rate's going to go down or the infection rate's going to go down because we're vaccinating the vectors.
The question of how much children account for transmission to adults, to frail grandparents, whatever it is an argument some people make for vaccinating children as part of community level immunity. I would argue, and then you can get into a question of how well these vaccines prevent infection and transmission, which is a complicated issue. But I would argue we want to vaccinate kids to protect kids.
Okay.
It may help with teachers feeling more comfortable being back in the classroom, or school bus drivers being more comfortable. So that could be an added advantage. But I would argue the main reason we want to vaccinate kids is to protect kids.
I remember having this thought as soon as it became evident that if we could close down America for 6 weeks, I thought, literally, basically isolate everybody for like 6 weeks, that we could get through this thing, which I then feared could go as long as a year. Of course, that's been almost 2.5 years ago. So now you get to be king of the world. We get to go back and you can do what you want to do to stop the spread of COVID-19. What do you do?
Well, I think whether such an individual could do globally, for example, what China did in terms of really closing things down, being very draconian, using troops, et cetera. That really plausible across the world? Because I would argue that by March or April or May of 2000, this virus was already ubiquitous. And so accomplishing what China accomplished in terms of, quote, shutting it down, I just have a hard time seeing what any king of the world could have done, frankly. I mean, I know what people will say, well, we need to test everybody, isolate, quarantine, contact trace. I know about all those things. I'm very doubtful that would have, in fact, basically put this genie back in the bottle.
So how would you change, seeing what happened, having this hard evidence of what happened with the spread of the disease, go back and tell me what you would have done different in America? What should we have done?
Well, a lot of people have written about the fact that some of our problems, the reason we've done such a terrible job of controlling this virus and getting people vaccinated and other things compared to a number of other countries, is not because of lack of scientific expertise. It's partly to do with lack of trust at a much wider level, and people simply not trusting gray-haired Berkeley professors or public health officials or whatever. Part of it is the enormous fracturing of our country along political grounds, and this being a deeply politicized issue, and with different states really having leadership that I find deeply troubling around the approach to public health.
Hunting for the silver lining in every problem is an exercise that's hard, but it's also gives us some benefits. Are we better at creating vaccines because of the global importance of this most recent pandemic?
Yes, and I think that's probably one could argue that's the single most important good thing come out of the pandemic.
So Art Reingold, it's completely fascinating to be able to spend an hour with an absolute expert on public health. And thanks so much for sharing with us your knowledge, your insight, your time. You're a super valuable human being to our culture right now. And we in the Wednesday Yachting Luncheon have appreciated you giving us this second of 2 interviews in the last year and a half. Thanks so much, Art. And I owe you more than a beer at the bar at St. Francis Yacht Club. Thank you so much for being our guest on the Wednesday Yachting Luncheon.
Good to talk to you, Ron. It's been fun.
This has been a presentation of the Wednesday Yachting Luncheon.